My name is Kathy Lawley, and I'm very pleased to welcome you today to our webinar. Our speaker is Alyssa J. Alden, RN ACM, Director of Case Management and Coding at Wilson Health. Alyssa Alden is an accredited case manager through the ACMA. She is currently pursuing her BSN and holds an associate degree from Kettering College of Medical Arts. Alyssa has 27 years in nursing with 11 years in case management. During her tenure, she has implemented emergency department case management programs at both Wilson Health and implemented at Clinton Memorial Hospital, where she has worked for 22 years. Her career includes experience in the emergency department, obstetrics, infection control, quality, and managed care. Please help me to welcome Alyssa.
Hi there. First of all, I'd like to thank Kathy and thank MCG for allowing me to present today. I'm very excited to share some information from my experience that hopefully will help those who are attending, and also thanks to everyone who is on the line. So with no further ado, we'll go ahead and get started. 3 objectives that I would like for you to take away from today's webinar is first, to be able to describe how to use MCG in a case management setting to ensure that patients are getting assigned to the correct status. Secondly, I would like for you to be able to explain how case managers in the emergency department setting can use the criteria to identify possibly alternatives to coming into the hospital and to facilitate safe discharges. And thirdly, I'd like for you to understand the value of equipping case managers with care guidelines from MCG to support meaningful conversations with physicians throughout the hospital stay. And we'll touch on this quite a bit. We found this to be extremely helpful at Wilson. So first, I'd like to give you a little background on what type of facility Wilson Health is. We are a small, nonprofit, independent community hospital, still independently, run. We are not part of a network, which is fairly uncommon in the state of Ohio. I think there's only 2 or 3 hospitals left now in the state of Ohio who are truly community-owned, independent. Shelby County, it's located in Shelby County, which is about 40 miles north of Dayton. We're right off 75. We're about a stone's throw from 75, which is a major interstate in the state of Ohio. We're the #1 county in Ohio for industrial jobs per capita. We have a lot of industry in the area as well as agriculture, but significant amount of industrial jobs. So that definitely helps our payer mix. We always say in Sydney, if you want to find a job, there's a job to be found. Our population of under 65 years without health insurance is about 8%. We have about 8.9% of our population in poverty, and our median household income in Shelby County is $54,550. So that gives you a little idea about the community that we live in. Wilson Health itself is licensed for 90 beds. We average a census of probably about 22. So, very small. We have a med tele unit, we have a CCU unit, and then we do have an overflow second floor that we can take patients, medical telemetry patients, as needed. We have a medical staff of 250 physicians, 38 providers are hospital employed, and we have about 1,500 admissions per year. We're looking close to 30,000 ED department visits, and I think we're surpassed 30,000 this year. Do about 4,500 surgical procedures per year. We do have a hospitalist program that accounts for about 80% of our inpatients. So quite a large portion of our inpatients are managed by our hospitalist service. Our hospitalist service is made up of physicians who are here 7A to 7P, and then we have a mid-level here from 7P to 7A. So we do have 24-hour coverage, which is fairly recent within the last year, and so we're working to kind of really capitalize on having that round-the-clock coverage with our hospital program. We do have a cardiac cath lab. We have 2 groups of cardiologists that feed into the hospital. We have a Lima group that is north of Dayton that comes and sees patients and does procedures, and then we have a group from the south from Kettering. So we really strong in cardiac care, have 2 strong groups that work with us. So that's, a great benefit to our patients in the community. So building success. When I first come to Wilson back in 2014, the end of the year, we were just getting ready to go live with MCG care guidelines. Actually, the contract had been signed, and I was tasked with implementing MCG. I had come from a facility that used the competitor, so there was a little bit of learning curve for me, but I was so glad that we had that decision had been made prior to my arrival. So we really redesigned the department and just, it really evolved quite dramatically. Prior to my arrival, we had not really had a strong presence on the medical floors or with the medical care team, the nurses, the doctors. So we began rounding with our physicians. Our inpatient case managers began rounding with our physicians, mainly the hospitalists, and really started to develop some relationships with them. And I can tell you at first that was met with quite a bit of resistance. Not every physician was thrilled that we were doing that. But they did come to learn, some of the value of that and appreciated that. And now they actually come to our office and say, "Where's my case manager? I'm ready to round." So as well, we started having multidisciplinary daily rounds Monday through Friday. We do those at 1:30, and we try to make it no longer than 30 minutes, and we go through every acute care patient in the hospital, being Med-Tel and CCU, and if there's any patients on our second floor. We started placing staff on the nursing floor and in the ED. So initially, I vied for some space on the 3rd floor, which, that was a challenge, but we made it happen. We have a small office on the 3rd floor, so they have a presence. They're there, which makes it extremely convenient for the case management staff as well as the providers to be able to have interactions with them. And then we, I think it was about December of 2015, we put ED case managers in place in our emergency department. Started with 1, and we'll talk about that in a few slides, but that was pretty profound and quite a new idea for this facility, so that was exciting. So we started actively engaging with our physicians, attended ED provider meetings monthly, and started gearing up for that ED case manager coming in. So we also put frontline staff representation on our UR committee, so we have a social worker and a case manager on our UR committee, which was important to get them kind of interacting, seeing the issues, having someone who can speak directly to what's occurring on the front line. So when we talked about the emergency department case management program at our facility, it was made pretty clear to me that if we did not show success with this, this could be something that we would not continue, that we definitely needed to be able to show its value and its success. So one of the big problems that we were currently having is that we had a lot of patients placed in the incorrect status, and we were constantly correcting that. It was an issue. My case managers were having to spend quite a bit of time on the inpatient side getting orders corrected, getting cases reviewed, and it was really impeding their ability to be case managers with the inpatients. So 2 metrics that we developed that we determined we were going to measure was conversion rate of observations to inpatients, and then our conversion rate from inpatient to observation, and specifically condition code 44s. So those were 2 things that we determined. My structure is I report to the CFO, and those are, those numbers mean a lot to them, so that was important. Our second thing we wanted to do was improve documentation in the ED record to support medical necessity. We felt by having an ED case manager right within earshot of those providers and concurrently looking at charts that we would have the ability to help them improve the documentation, which we have. And then facilitate discharge planning when admission is not necessarily medically necessary. We would get social admissions occasionally. We haven't seen a social admission, I can't tell you when perhaps, grandma's come in, she just can't take care of herself anymore. The family doesn't know, what to do. They say they can't care for her. We don't have a safe discharge plan. So we would put them in the facility as an outpatient in a bed, or if they met observation criteria, we would go that route until we could get them placed the following day. And those can be challenging. So now we really have, with having an ED case manager down there, we can address those issues in the department, which is best for everybody to get that patient to the correct level of care. So decreasing average length of stay for observation with MCG. So by initiating the ED case management program, we first looked at what hours makes the most sense to meet our highest volumes. So we ran some stats to see what hours of the day does it make sense to place a case manager in the department. And for us, it was 12:30 to 9 p.m. I only had one FTE to work with when we first started the program. So we made the hours 12:30 to 1 p.m. We actually started with that Monday through Friday, and then found that Sunday was a big admission day for our facility. So we did change those Sunday to Thursday. So we kind of started out small and had one person who I trained, spent several weeks down in the ED with that person side by side. And she had been a previous ED case manager, or ED nurse, I'm sorry. And I do recommend, looking at your ED nurses, because if you're starting a program, because many times they have the credibility of the providers, and it's an easier transition for them. I've hired both ED case managers from outside of the facility as well from inside the facility, and I have found, for whatever reason, and maybe it's because we're smaller, it's difficult for folks who come from the outside. EDs and ORs, I've always said, tend to be very close-knit departments and a little difficult to break into sometimes. So it's just one less barrier you have to face if you choose someone from the inside that has strong credibility with your providers as well as your nursing staff. So what we decided to do once we got this person in place and got them trained is that they would do the initial MCG review and appropriately status the patient from the beginning. So for lack of a better term, they are the gatekeeper of the ED, and that has worked so well for us. So the other thing that they do by being here in the evening hours, they can follow up on potential observations that could be switched to inpatients if they've ruled in, or should they go home if they've ruled out. And so they can really follow up and provide us some additional coverage in those evening hours. And then converting a patient to inpatient if the discharge criteria fails. And we do that quite often. So that's, those are the key things when we first started the program that we worked with. And of course you see here the observation care discharge criteria. So if they do not meet this, then we need to be looking to admit those folks. And that's exactly what we do. So we're very aggressive in managing our observation patients. So we use it to ensure appropriate status. We review the chart concurrently. So what we tell the providers, and I do attend, and this is something else I would recommend if you're looking to get more engagement, is get on the committee for your ED providers. We contract both our ED providers and our hospitalist providers with one company, and they have a monthly operations meeting that I attend and provide stats and provide, we have dialogue about what's going well, what's not going well, and that has really helped build the program since it's, we're so closely connected to the providers. So we ask that our providers, as soon as they see a patient, if they feel that that patient is a potential admission, and I worked in the ED for several years, so I've got a good ED background. Most providers have an idea if there's like no way this patient's going to go home. They're going to have to come into the house right out of the gate. They usually can tell that after the initial assessment. Sometimes you're surprised, but many times they have a good idea who's going to stay and who's not. So once that provider tells the ED case manager that this patient is most likely going to need to come into the house, they can start reviewing that chart concurrently. And they can identify things. Perhaps it's a COPD, kind of on the borderline, they may suggest to the provider, Dr. Smith, does it make sense to get an ABG on this patient? Or an asthmatic, could we get a peak flow? Would we be able to order that? And it's amazing, as we've done that, they are starting to think that way, and we find that they are doing that without being cued to do so. So the ED case manager is going to review those clinical indicators after she's or he has looked at the chart and make, under the appropriate diagnosis, and determine, we always have them look at admission criteria first to see if they meet criteria to come into the hospital. And then they start having that dialogue about, are there additional diagnostics that might help make that patient appropriate for inpatient. And our goal is always, we would prefer the patient to be an inpatient, as I'm sure everyone would. So we do look at admission criteria first, inpatient criteria first. So for example, you have a patient that has pneumonia, and you're going to start initially looking at those clinical indicators, as you can see here. And so they're reviewing this chart concurrently, and the workup is being done, things are starting to come back, and they're starting to collect information to determine if they meet the criteria. Under review and indications for admission, one thing, so say that they would, we don't know what their room O2 stat is. We would, ask the nurse, can you obtain a room O2 stat, or ask respiratory if they can provide that for us. And we know if that's less than 90% on room air, then we're looking pretty good for an inpatient admission. So we can kind of go through this and make sure that we are doing a thorough workup. Obviously we're not going to be ordering tests because that's out of our scope of practice, but we can sure provide suggestions to the provider. And typically, if you have a good relationship with those providers and you're working for that, that becomes a very natural conversation. So did the patient, one thing we always tell the case managers to ask themselves is, did the patient respond to treatment in the ED, and can they be discharged? So if they can be, did we do all the appropriate things, and then what level of care do they need to return to? Do we need to consider setting up some home care for this patient? And we do set up quite a bit of home care from the emergency department. Or if they're from a skilled nursing facility, from a SNF, does it make sense that they return to the SNF? So we can coordinate and facilitate those things. If they're a DNR-CC and families really just wanting to keep them comfortable, they're not hospice appropriate, they come in with a pneumonia, does it make sense for them to return to the SNF and receive those treatments there? So we're looking at all those things. A lot of complex decision making is happening during that time, but we found that this is time consuming, and I won't tell you it's not. It's a time consuming thing, but we find that if we take the time and do it, it really saves time in the long run, and it's what's best for the patient. I mean, we're always looking to get the patient in the most appropriate level of care. So it also builds a lot of credibility with you and the nursing staff, with the physicians, because they see that as a win, and they appreciate that you're willing to take the time and to do that, and it's definitely worth it in the long run. We all know the old saying, when in doubt, let's put the patient in the hospital, and that's exactly one of the other goals of the ED case manager, is to facilitate disposition to the most appropriate place. And like I just said, it's time intensive, but it's worth it. It builds trust and credibility. The things that we have done from the ED is SNF placement, home health care, and we've set up DME. Perhaps they need a walker, perhaps, and we've actually even had our physical therapists come down and do what we call a mini eval and provide some guidance for us around recommendations for equipment, or do they need PT at home with home health, that type thing. The other neat thing that we've been able to do here at Wilson is we've been able to do some contracting with the facility, our local SNF facilities, and with the hospital to expedite SNF placement. And how we do that is that we are willing to pay a per diem, per day rate to the nursing facility until they get pre-cert from a managed Medicare. that has helped us tremendously. Something you might want to think about, but if we have a PT mini assessment and we feel confident that they meet criteria for a SNF, we will, but they really have no medical necessity to be in the hospital, we will send them to the SNF, understanding that once they get the pre-cert, whether it be an approval or denial, our responsibility ends. So that's something you might consider in your own hospital. If the patient is not being admitted, have we done everything we should in the ED? And so this alternate care planning, great tool for your ED case managers, provides you, kind of a down and dirty of all the things that we might have considered to, diagnostic-wise and treatment-wise before the patient is discharged to another level of care. So it just kind of helps make sure we're not missing anything. Did we not, for some reason, not do a chest X-ray on that pneumonia patient? Well, that would be definitely probably an oversight, and we would want to bring that to the provider's attention. So it's kind of just a quick checklist. Is there anything else from a diagnostic standpoint that would make sense to do on this particular patient? These are great tools. The other thing I will tell you is that when I hired the ED nurse to become the ED case manager, we spent a lot of time with the MCG criteria and had her pretty comfortable with it. We actually just had her doing some reviews up on the floor. She did, through LMS all the modules. That was extremely helpful to her, that she had some real good fundamental knowledge of MCG before she got down in that setting. And that setting can be chaotic. It can be kind of loud and crazy. And so it's best to really have that case manager fairly familiar with MCG and the tools that it has to offer before you put them in that setting so that they can be successful. I mean, the goal is we want to set them up for success. Statusing of the ED patient. So get the patient in the right status the first time. That is our goal. We know that we're going to have some, conversions from OBS to in. That's to be expected. We monitor that monthly. We benchmark ourselves against the National Advisory Board, which we've built a cohort so I can look to see, are we close to that number? I think we still have room to improve, but we've definitely made strides in that. So, the ED case manager reviews the patient record, obtains the necessary documentation, they have a conversation with that provider, and they provide a recommended status. Now, at our facility, I will tell you that our ED providers do not have admission privileges, that they are not able to admit. So it truly is the attending who's responsible for that status. So when the ED physician calls the attending or the hospitalist, they have that conversation. Ultimately, the attending is the one who is responsible for the status order. So I always, that's the person they need to speak with if it didn't, if it's not appropriate. And that just tells like it is. The ED case manager can always speak to them on the phone, and we can proceed with a second level review if necessary. So if the attending's like, I really want them to be an inpatient and they're not meeting criteria, we say that's fine, Dr. Smith, we'll be happy. We use an outside company to do a second level review, and so we would proceed with our process. So how has this impacted our observation stats? So you can kind of see from 2015 through 2017, our observation conversion rate has come down very nicely. Could not be more pleased with that. I'd like to see that get down to about 25 to 27, but we are definitely have made significant gains, and I would say that's clearly related to having an ED case management program and having the MCG criteria in performing that first review. Total observation hours, we've had an 11% decrease from 2015. We kind of popped back up in 2017. We had, and I think part of this is attributed to we changed our contract with our hospitalist service, and so we had for a period of time kind of a mixed mash of hospitalists coming into the facility, and I think that really didn't have a lot of continuity at that time, but we're on track this year. But overall, good success with that. And the number of status changes from inpatient to observation And you can see we had a significant decrease, 73%. We're averaging maybe, not even quite one a month. We had 10 last year total. So those metrics that we had set forth at the beginning of the program, we were seeing success. And with that, the decision was made to expand the program. And so actually I'm right in the process of finishing up orientation for 2 additional ED case managers. So we'll be providing 7-day-a-week coverage, 12 hours a day. And those hours will be for us 10 to 10:30 p.m. So we're super excited about that. And I will tell you that had we not had the criteria to use, had we not really set forth what our goals were with the program and built those relationships with the ED providers, I don't know that that would have happened. I can tell you the reason we got those additional FTEs, part of it was around the ED providers really going to bat for us and being supportive of the program and wanting increased coverage and telling administration, we need more ED case managers. They really appreciate our services, and that's a direct reflection of the team and working with those providers. Impact on our average length of stay for observation. You can kind of see how that, we started out at 31 hours in 2014. Year to date this year we're at 28.8. Last year we averaged out at 28.3, and so we've seen an 8.7% reduction from 2014. What I will tell you that, when it comes to observation hours, small gains are, that's huge. It's difficult to move that needle. You don't have as many hours to play with. It's difficult. But we have really made strides toward that. We talk about observation every day in Daily Care Conference. Our observation patients, it's noted their observation. It's noted when they come in and how many hours they are. So it's really at the forefront of the provider's mind as well as the case managers. We also have a large tracking board on the 3rd floor that calculates the hours for observation and has those listed by the patient, which is helpful to our providers as well. It's another visual cue to them. This patient is observation, and this is how many hours they've already been here. So those things together have been helpful for us. And again, we aggressively status these folks. We're looking at them probably 2 to 3 times a day, which is also helpful in reviewing them. So what are some of the lessons learned since I've implemented the ED case management program? I would say first you need to have buy-in from your providers and nursing staff. So we did talk about this for a few months prior to implementing it, and we talked about what it would look like and what our goals were going to be and what our metrics that we were going to measure. We also talked to nursing staff to let them know how this person's going to fit into the equation. Specifically, from the point the decision's made to place, the patient in the hospital, either as an inpatient or as an OBS, till the time they're head in a bed. So that we have an SOP for that, a standard operating procedure, and so that had to be altered somewhat to, be able to plug that case manager into the appropriate places. So really doing some pre-work. Candidate with strong ED clinical experience and credibility. Can't stress that enough. That will make a big difference. If you have the ability to do that, I would do it. We talked about a candidate that's worked in your ED. Position your ED case manager next to or within an earshot of the providers. And that's sometimes, you got to really work to get that to happen. But if they're in an office down the hall, they're not nearly as effective. When they can hear those conversations that providers are having with other providers or with someone on the phone, it makes a huge difference because they kind of can sometimes know what's coming before the providers even had a chance to talk to them. So that's key. They have to be within an earshot of the providers. I mean, they really need to be somewhat of an extension of the providers. Familiarizing the ED case manager with the criteria, MCG criteria, prior to starting the ED program. So that's also extremely important. That also helps build that credibility and helps decrease the stress of your case manager. Using data to drive hours staffed. Don't be, like I said, don't be afraid to make adjustments as needed. And, I told the case manager the ED case manager when I hired her, this is where we're starting. This is where I want to be. There might be some adjustments made because, we're here to serve the patients, and that's what we need to do. So, you got to be upfront with them about that, but you have to let the data drive the hours staffed. It's typically not a 7 to 4:30 job. That's not when you see the volume in the ED. You want to get the most bang for your buck when you have somebody down there, especially when you're really beginning and you have to kind of prove the program before you're going to get additional coverage. I'm going to kind of transition over to the inpatient case management program to talk about how we really use the criteria to engage our physicians on the inpatient side of care. We did this through ensuring all the appropriate interventions are being ordered through the optimum recovery course, having conversations, rounding with the attending daily. Some of the nurses now, not so much, but at the beginning, printed off the care task list when rounding with the attending or using a rolling laptop to kind of make sure we were hitting all the high points of things that we needed to be doing to move that patient through the continuum of care. And also using the care task list during multidisciplinary rounds. We call it daily care conference as well. If the patient's meeting all goals, when I train the case managers and train the trainer, I always say if they're meeting all their milestones and all their goals, that case manager needs to be asking herself or himself, why is this patient still here? Is there is there something else going on with the patient that has not been identified or not been documented appropriately? Do we need to add another guideline? Perhaps now they're having acute kidney injury or acute renal failure. Or is it an avoidable day? Are we waiting on a consult that hasn't occurred, that needs to occur? And, do we need to be collecting an avoidable day for that and documenting that? So if they're meeting all the milestones, that case manager needs to be asking, why are they still here? And by having that relationship with your physician, that conversation is much easier to have, or you may already know the answer by rounding. So. The optimal recovery course, so you're going to use this, so you pick your first, and we're still going with pneumonia here, you pick that pneumonia and then you're going to look at how that patient in the perfect world should progress each day. So you're going to be looking for those milestones that are highlighted in purple, wanting to make sure, things are moving through. And if they're not moving through, why not? Is it just a matter that things didn't get ordered appropriately, or, this patient wasn't started on a pneumonia care path? You want to figure out why that is. Utilizing the care task list when rounding. So this just talks about, most of the time our experienced inpatient case managers have our big diagnosis memorized, like pneumonia, COPD, CHF. Those are some of the 3 common ones that we see. So they almost have this memorized now. But you want to be making sure that we're doing all the right things. Have we had culture results come back? Are we seeing that white count trend downward? If they're not progressing clinically, have we considered ordering a CT? Those types of things. This is very helpful to make sure that we're moving that patient through the continuum of care. Have we increased their activity? Are they moving? Do we need to get PT involved? All those things, need to be going through that case manager's mind when she's seeing that patient during rounding and when she's looking at the orders and such. And then, the great time to really to act on this is when we have our daily rounding, when we have all the team members in the room and, we can have that conversation. We have the hospitalist there, so if we need to get orders, we can. There's a computer there, we can put those orders in and get things moving toward discharge. Communication's the key. Again, I can't tell you how important it is to build those relationships. Another great time is to approach them when they're rounding, when they're completely focused on that patient. And here's some examples. Dr. Smith, I noticed Mary's a lot less short of breath today and still on 2 liters of oxygen. Would you be agreeable to ordering a room oxygen sat on this patient? Try to get her weaned off that oxygen. Again, that's moving toward discharge. Dr. Smith, I noticed your patient Mary's still in bed rest. She states she's feeling stronger and would love to, be able to get up and ambulate to the bathroom. Do you feel that we could get an order, it would be appropriate to get an order for up with assistance, that type thing. So I found that physicians are the most, it's the easiest time to ask them these types of things when they're actually rounding on that patient. And a lot of times the patient, is there saying, yeah, doc, I want to get up and move around. So it just makes sense. Knowing the patient's discharge needs. So, you get really efficient. You're getting these patients moved through the continuum of care. You've got to be ready to have a discharge plan if you want your provider to discharge them. So utilizing the general planning discharge tool can be very helpful into ensuring that we're putting the patient in the right level of care. Do they need home care? Do they need a SNF? Again, these tools are available to the ED case, or to any case manager, not just ED, to the inpatient and the ED case manager at their fingertips. Just getting them, comfortable with the tool and able to use it. And again, these tools are excellent for a new case manager. Setting the expectation for length of stay. So the other thing that we found is that a lot of times the expectation was being set by the provider that was somewhat different than from what the staff was telling the patient, the nursing staff, and then we were coming in as a case manager and maybe telling them something, a third idea of when the length of stay was going to be. So we try to set our goal length of stay, and we write that on the board when we're rounding with the physicians or speaking with the patient, and we use the MCG criteria to help guide us for that as well. We talk about that length of stay with the patient. We talk about it in rounds as well and in our daily care conference, and we write it on their whiteboard. So, we always preference it that most patients with pneumonia stay an average of 2 days. That could be a little longer, a little shorter, but that's the average. And we start out with that on day 0 or day 1. And then if we need to adjust it because of other issues that are occurring with the patient, we do. But at least they've heard that, they have it written on the board for their family and other, significant other to see that. So that's really important to set that expectation. The impact of using the MCG criteria when it comes to engaging the physicians on the inpatient side, again, we were looking at inpatient length of stay, and you can kind of see there we overall have had an increase of our CMI, which is excellent. So that's telling me we're getting better documentation from our providers showing how sick our patients are, of 9.76. And then, I'm sorry, now I'm 3.8%. I apologize for that. And then we've seen our inpatient average length of stay. Year to date, we're at 3.33, which is just excellent. I'm really happy with that. But we started at 3.69, and we've slowly gone down, and our CMI has gone up, which is good. And the initiation of collecting the avoidable days for our inpatients has been helpful too. That is shared, that information is shared at our UR committee, that flows up to our med exec, that flows up to the board. So, that's hitting the right eyes. What I will say about avoidable days is that the variance days, can be used the same way in MCG. We chose to go a different platform just because our managers were already using a different platform, and it was less of a learning curve, and we thought we'd have better success with that. But, focus on maybe the top 2 highest areas that have avoidable days and try to put in some interventions to mitigate those. Again, you're always going to have some avoidable days, but if you can, tackle 1 or 2 at a time, I think you'll have better success with that. So in summary, I just want to say that to me the communications and relationships are key. Our case managers do both the utilization and the discharge planning, which I know, every model does not have that, but for us being so small, that worked the best. You want to be sure they're able to understand the criteria, the MCG criteria, and able to translate that into a conversation with a doctor or a provider. You want them to have really meaningful conversations with those providers at the right time, in the right setting. I think, you're going to set them up for success if they do that. I can't stress how important it is to provide education to the providers. At every turn, I try to provide education. We're now involved with onboarding new hospitalists, in the interview process for new hospitalists and new physicians. That's key. I mean, because you can ask a lot of questions to a potential new physician or hospitalist that can lead you to know, are they a collaborative thinker? Are they somebody who's going to be open to case management? That can be helpful from our perspective. Providing metrics to physicians, contracts related to case management. One of the things that we saw successful is that when we started with our new hospitalist group, we put 2 case management metrics in place with them, one being percentage of attendance at our daily care conference, because we feel like that hospitalist or mid-level is key in the care of the patient, and it's very important that they attend that. We also put in a percentage of discharge written for by 11 a.m., because we know that the ED is revving up in the afternoon, and we're trying to get patients out and we're trying to get patients in, and it creates kind of a backlog. So that was another metric we put in place. So anytime you can influence behavior through some metrics in contracts, I suggest you do it. Again, providing data to that C-suite. First of all, agree on what that data is going to be and what the metrics are going to be, and then providing that data to the C-suite is imperative to grow the program. And then focus on one problem area at a time. And that is how we've had some success here at Wilson. So I will turn it back over for any questions.
So yes, we have some questions here in the queue. First, would you like to comment on how the 2 midnight rule has come into play, or if it has come into play with your project here?
We do not solely make decisions based on the 2 midnight rule. What I can tell you is that if we have an observation patient who is going to cross the second midnight and we are still providing treatment and they are still need to be in the hospital, we will make them inpatient. But if they're sitting in a bed because they're waiting on something from us, for instance, a cardiology consult or what have you, and the delay is on us, we don't automatically switch them to an inpatient just because they're going to cross the second midnight. We still look, heavily at medical necessity using our criteria. If we have a question, we would send that to our second level review if the physician is agreeable with that and feels that they are going to have to be here a second midnight. Does that answer the question?
I think that's a good answer. And the next question will be, you did comment on observation to inpatient status and how you had improved that. Is that, and I know you had also put some times in there, was that same day or all observation to inpatient?
All observation to inpatients.
And then we also have a question on ED observation rate. You mentioned it went down. Is that reflected because of the number of patients who converted to inpatient?
No, our ED observation rate went down because I think prior to that, we had providers who didn't know what status they should be in, so they just put them in OBS because they thought, well, that's the safest status to put them in. So I think that's why that went down, because we were aggressively statusing them, and if they met inpatient or if we needed, just maybe an additional diagnostic like an ABG for them to meet that first, line criteria in MCG, we requested that test be ordered. So I think that's really why it went down. And
then can you comment on your case managers rounding on the floor with hospitalists? Do they round with hospitalists, and if so, what time do they spend?
They do round with hospitalists. What I will tell you, when we first started, they rounded pretty exclusively with a hospitalist on about every patient. Now again, we're small, so the average hospitalist census might be 14 to 18 patients. The other thing they did is my main inpatient case manager, she adjusted her hours somewhat because we had a lot of providers that were non-hospitalists that come in around 6:30 in the morning. So she started coming in at 6:30 in the morning so she could have a conversation with them before they left to go to their office, and we usually didn't see them again. Now, how long did it take? He or she would round sometimes up till noon. So she also had she had a workstation on wheels, like a computer on wheels, so she could work in the nurse's station on her computer while he maybe was doing documentation or what have you. So she was still being productive. The other thing is, now that we've really developed that relationship, and I feel like our dialogue with our hospitalist is so good. I will say she doesn't have to round on every last patient with the hospitalist. If we have a problem patient or a patient we're not sure should be converted or what have you, she might round on that particular patient. As what I will say too, as well, with doing that, you really have an opportunity once you develop that relationship with your hospital to have some influence on what patients, the order of patients he or she is seeing. So, for instance, if you have 2 or 3 observations and he's already or she's already seen the unstable folks or anybody that needs something right away, then she or he could suggest to the hospitalist, hey, would you mind, I noticed Mrs. Smith's in observation, she's already been in obs 14 hours, would you mind taking a look at her next? And we've had good success with having some influence over that as well.
Okay, and then Alyssa, we've got a few questions here on denials. So I'll try to put these all together here. So have you seen a change in your denial rate? There's also a question related to denials and any denial rate for patients who were in observation, converted to inpatient, don't meet the discharge criteria or the severity of illness. So I think that's probably a golden question for all of us.
So, first of all, I don't think we have not seen an increase in our denial rate. It's stayed pretty steady. What I will tell you is that we aggressively manage denials. Our physician advisor does peer-to-peers. So kind of what our process is if we do have a denial, the UR clerk will put together a packet and provide that to me, and I'll review to make sure that the criteria was applied appropriately. And if it was, and it met criteria, then we ask our physician advisor, or UR physician advisor, to do a peer-to-peer. So then we set that up, and he does that. I can tell you he has become very good at those, and I should really look at what his rate is, but anecdotally I would say he's probably about 40 to 45% overturn rate on his appeals. If he's not available or out of town, we will have our second level review company that we're contracted with do that appeal, that peer-to-peer. What was the other part of the question? I'm so sorry.
Oh, no, that's okay. There was a question about the denial rate. If you have this tracked, actually, there was a couple of questions about your denial rate, if you know your denial rate, and if you have a rate on patients that were in observation, converted to inpatient, but didn't meet the discharge criteria or the severity of illness for inpatient.
I do not. I do not have that number. It hasn't been significant enough that it's gotten on the radar that we need to track it that closely. We have not seen a large impact. Again, what I will tell you is that we look at that discharge screening, the observation discharge criteria. If they don't meet that, then our next question is, why don't they meet that? I mean, what particular thing is it, and are we actively treating it? And is it appropriate that they stay another midnight because of that? So, we have conversation, dialogue with the physician. Many times they can tell us, I can't send them home. They're not able to tolerate a diet yet. They've had vomiting. And then we look to see, have we been treating the vomiting with what have you, Zofran or Phenergan or what have you. If we're actively treating it and they can't obviously go home if they're vomiting and they fail that discharge criteria, we do try to convert them for sure. If we have any question, and we still call our second level review. If it's on the fence, we'll call them, so that at least we have that added protection and have that letter in the chart with with their recommendation. So I hope that helps.
And then, Alyssa, did you spend time educating your physicians on the actual MCG guidelines, or do you just utilize the case management team to share that information?
We just utilize the case management team to share that. Now, I will say our physician advisors had more education than our providers. It's funny that you asked that, because when we contracted with the new group for our emergency providers and hospitalists, they really wanted that criteria. And I'll be honest with you, I'm a little hesitant to give the providers the criteria without providing the proper training, as well as, we all know that some patients are going to not meet the criteria that are appropriate for inpatient. I mean, it's a first level criteria that it's not, the end-all be-all by all means, and it's written, it's for the scope of a nurse practicing. So I hate to put ourselves in that box, because there are patients that we have that are appropriate for inpatient that may not meet the criteria. And I don't want to say they could never be an inpatient because of that. So we have educated our UR physician advisor. He's very familiar with the criteria, because when he does the peer-to-peer, he wants to be able to speak to that specifically, or at least know if it didn't meet, and we used a second-level review, what things did they feel was appropriate that made it a inpatient.
And then can you comment on your staffing for the nursing units? How many FTEs do you have, social workers also mixed into those FTEs?
Sure. So currently on the inpatient side, I have one FTE case manager and a casual case manager, both of those are RNs. Then I have one full-time social worker upstairs, Monday through Friday, and then I also have one other FTE for social work, so a total of, it's actually 2.1 FTE for social work, but we also cover the BHU unit, my social workers do. So every day my staffing is 1 and 1. I have one on the inpatient side and one on the BHU side. Now, if our census goes high enough, I can call in a third one to assist with the inpatient side. Our BHU unit's 10 beds, so one social worker, that's their capacity, is enough. Case manager-wise, it's about 1 to 20, 1 to 15 to 20. Our average census is about 14 to 18, but if we are going to have more than 20, I try to have our casual case manager come in and work. We do have an ortho who does, he does all of his joints in 1 week, and so we know those weeks are heavier weeks for us, and so we staff accordingly. In the ED, we will now have, let's see, we have 12-hour a week, 12-hour a day, 7-day a week coverage. So I have a 0.9, a 0.6, and a 0.6 down there. So 1.2, about 2.6, I think. So yeah, we have, and we haven't got to that point. We're just starting that. So that's where we are with that.
We have a question. Are you using the rapid review guidelines, or are you just using the inpatient care for admission criteria?
We do use the rapid review guidelines. We don't document on those, but say that it's just a crazy day in the ER and the ED provider, gives you 2 at one time, and you just got there and you haven't had a chance to really look at them, but they need to, they need to get status. They will bring those up and look at them side by side and make a decision, and then once they get that done, then they'll go back in once things have settled down and do the full review. And if they need to type out clinicals and all that, they'll do that at that time.
And I think we have time for one more question here. So the question is, how do you engage the nurses to use the optimal recovery course?
How do I engage them to use it? Well, really, it helps them, and I think if they understand the benefit of that, because when they have conversations with doctors, and sometimes, the case manager's nervous about doing that initially if that's not something they've been accustomed to doing, that is just building knowledge for them to be able to have that conversation that's meaningful. So I haven't found a lot of resistance to that, because I think when they go out there and talk to those physicians, they want to know what they're doing and talking about, and that optimal recovery course helps them. It's evidence-based, so they have references if the doctor questions them about it, but we've really never had many physicians question us. They're saying, oh, thank you for reminding me about that. I forgot to order that, or what have you. Like maybe they missed ordering an antibiotic for a pneumonia, and you said, Doc, do you want to order an antibiotic? And they're like, oh my goodness, thank you. So now we've had hospitalists say, if it wasn't for so-and-so catching that, I'm not sure I would have remembered to do that, or a statin and aspirin for a stroke. It just really helps build credibility, and makes your case managers definitely be in a good light, because they have quite a bit of knowledge. So from those guidelines, they've been able to convey that in a conversation.
Okay. Well, that's all the time we have left for today's presentation, and I would like to thank Alyssa, our speaker today, for a very informative and engaged presentation. Thank you for everyone for your attendance today, and we are, if there are any questions at all and you're an MCG current client, you can reach out to your MCG account manager or your sales executive. I'd also like to remind everyone the presentation has been recorded, and you will receive the link to the recording next week. Also, if you liked today's presentation, I'd like to remind everyone of our upcoming MCG Client Forum, which is from May 15th to the 18th in Phoenix, Arizona. For more information on this, please visit the Client Forum registration site on our website. Thank you, everyone, and have a great day.